Ladies and gentlemen, welcome to MedSynapse podcast series. I'm your host, Dr. Nigar, and I'm honored to have Dr. Rutendo Rukarwa, a dedicated consultant specialist physician and rheumatologist at Rheumamed, South Africa. Known for her patient-centered holistic care and evidence-based medicine, Dr. Rukarwa specializes in managing internal medical conditions, joint and muscle issues, autoimmune diseases, and connective tissue disorders. Today, our focus on the management of systemic lupus erythematosus. We will delve into the various aspects, including the primary symptoms of lupus, the challenges faced by individuals living with this condition, the different types of lupus, and their unique management strategies, recent advancements in lupus research and treatment, and the crucial role of multidisciplinary approach along with lifestyle changes in supporting overall well-being for individuals with lupus. Join us on this insightful journey as we explore the intricacies of lupus management with Dr. Rukarwa's expert insights. Welcome, Dr. Rukarwa.
Thank you so much, Dr. Nayer. Thank you so much for having me. A lovely day today. It's hot in Botswana, so yeah.
Thank you so much for joining us on MedSynapse podcast series. Now let's begin with the podcast. Dr. Rukarwa, what are the primary symptoms of lupus, and could you provide an overview for our audience on this?
So lupus is short for a disease that's called Systemic Lupus Erythematosus, or in short, most people know it as SLE. And as from the name, you can gather that it's a systemic autoimmune disease. Therefore, it means all systems of the body can be affected from head to toe. This occurs when one's immune system starts attacking its own tissue, causing widespread inflammation and damage to organs that are affected by the disease. Lupus erythematosus is an inflammatory connective tissue disease, and it is as a result of generalized autoimmunity characterized by pathogenesis of what we call autoantibodies and the development of immune complexes that then deposit in these organs and cause damage, and this is as a result of loss of immune tolerance. And basically what this means is that normally your body should be able to identify these autoantibodies and get rid of them when damaged, but because of a genetic predisposition, environmental factors, there's loss of this immune tolerance, and the patient develops autoimmunity and this enhance the disease. So in terms of the most common presentations of lupus, most commonly the disease can be mild or have a very aggressive course. And the most common symptom involved include the joints, where patient usually presents with joint pain, either in the form of arthralgias or inflammation, which we call arthritis, which can be associated with significant early morning stiffness. And this usually results in a non-erosive arthropathy, causing deformities, and can commonly present with what's called a Jacques arthropathy, where there are no erosions. You get deformities that are reducible, but sometimes these patients can also develop an overlap with rheumatoid arthritis, for example, which is commonly called lupus. And in these cases, the patients develop an erosive arthritis similar to rheumatoid arthritis with deformities that can become disabling and non-reducible. Another common presentation involves skin, which is common very early, especially in early disease. And usually when it flares up, you can get development of rashes. So the most typically known pathognomic rash for lupus is the malar rash or the butterfly rash, which involves photosensitive rash developing on the face of the patient, but with the sparing of the nasolabial folds. And these rashes typically heal with no scarring. We call them acute rashes. However, they can develop permanent hyperpigmentation. And another common rash, which is part of the chronic rashes in lupus, is what's called discoid lupus erythematosus. So this is where you get disc-shaped lesions that commonly occur in the face, in the head, in the ears of patients with lupus. And this is more common, especially in our African population, compared to the malar rash, which is more common in the Caucasians and other ethnicities. And this causes permanent scarring as well as hair loss, which can cause permanent hair loss in the patient. So these are the milder forms of lupus that can present with the patient, as well as commonly especially early disease, they present with alopecia, which is hair loss or hair thinning or easy breaking of hair. And however, this can be reversible once the disease is under control, where they get non-scarring alopecia. But you might need to be mindful that also the drugs we use for treatment of lupus can also result in alopecia. So the mild disease forms are mostly these presentations. However, you can also get major organ involvement, and this is where you get a lot of morbidity and mortality associated with lupus. So major organ involvement include things like kidney disease, where the patient typically presents with what's called lupus nephritis, where there is damage and autoimmune deposition in kidneys resulting in proteinuria, as well as nephritic patterns, and if not treated, can actually present with end-stage renal disease and patients needing renal replacement therapy and even transplant in these patients. Other major organs that we worry about in lupus patients include cardiac presentations, where they present with pericardial effusions, myocarditis, which can be life-threatening and need aggressive therapy. And other organs, major organs we worry about are your central nervous system, as well as your peripheral nervous system, which can be involved in lupus. And other organs include muscles, where they can present with inflammation of the muscles, including myositis. And rarely also typically they can present with hematological manifestations. So these patients present with anemia, usually of chronic disease, and other causes of anemia, including autoimmune hemolytic anemia. They can present with thrombocytic thrombocytopenic purpura, which needs to be managed aggressively as well. And commonly they present with cytopenias such as thrombocytopenia, lymphopenias, leukopenias, which is common in these patients. So there is a broad presentation in these patients, very heterogeneous, and no two patients with lupus ever present the same. Hence, it needs for early identification and diagnosis of these patients.
Thank you, Dr. Rutendo, for outlining the symptoms. Now, based on your experience, what specific challenges do individuals with lupus commonly face, and how can healthcare professionals effectively address these challenges?
So, lupus is a chronic disease that carries a high morbidity and mortality. And when we look at the epidemiology of the disease, it normally affects young females at a ratio of 9:1 with the males, and females of childbearing age. So we can see how this disease is very disabling in this population group. And the main challenges faced with lupus patients are many, and at times very complex to navigate for both the patient as well as the healthcare professionals and rheumatologists looking after this patient. So no two patients present the same in terms of their progression of the disease, clinical presentation, as this is a very heterogeneous group of patients, and each patient faces various challenges, ranging from mild disease, which can be relapsing and remitting, to some taking a very aggressive course, which can present with outright life-threatening disease in these patients. So the fact that it's a chronic disease, it affects the quality of life of patients, and at times it affects employment, where patients end up needing to stop being employed or fail to be employed because of the disease and its severity. It affects their family life as well as activities of daily living due to the disease activity itself, as well as the damage that is associated with the disease. So damage is when you've got the disease causing permanent disability, which cannot be reversed either by treatment or other supportive measures, and this can also affect the patient. And the most frequent admissions for these patients with lupus is usually as a result of either disease flares, where they get now new organ involvement or recurrence of organ involvement, so they can present with renal flares. Thrombosis is also a common cause of admission, so these patients are at higher risk of DVT, deep vein thrombosis, as well as pulmonary embolism. Another risk cause of admission in these patients is infection. So patients with lupus are at a much higher risk of infection, and this is multifactorial. Firstly, because of the disease itself, lupus is an immune-compromised state. So you find these patients have an immune system that's dysregulated, so there's a higher risk of the patient inherently developing infection. Also, as a result of treatment that we give these patients, where we now try to to dampen the immune system. Most patients are on long-term or high doses of corticosteroids, which also then predisposes patients to infections, especially in our setting in Sub-Saharan Africa. There's a high risk of TB in these patients as a result of glucocorticoid use, as well as the other immunosuppressive agents that we use that tend to suppress the immune system. So these patients are very prone to infection, and this can really affect the patient's quality of life. Another thing that the patients with lupus tend to suffer from is a lot of mood and cognitive issues, such as depression and anxiety, and this can affect their activities of daily living. Most of them end up dropping out of school, dropping out of employment, and some can even present with frank psychosis. I had a case of a young mother, 32, high functioning. She was a banker. She ended up with lupus psychosis, with neuropsychiatric lupus, and in the end, she inevitably murdered her 3 children because of the disease and the psychosis that relates. So you can imagine the toll it takes on a patient just because of lupus, and they end up with such a lot of complications as well as consequences of the disease that are not inherent in the patient. Toxicity and side effects of the various drugs is something that we also struggle with as rheumatologists, together with trying to manage these patients. So though they need the medication for the disease, you end up dealing with a lot of side effects and toxicities related to the medication, and hence you need to switch and stop, and sometimes you're not even managed to bring the disease under control. And like I mentioned, the majority of the patients with lupus are of childbearing age. So these are young females who need to and want to have children. However, lupus does affect fertility and outcome of pregnancies in these patients. So lupus per se doesn't cause infertility, except for when patients are given high dose or IV cyclophosphamide for whatever disease they're being treated with. So this can predispose the patients to develop premature ovarian failure, as well as in male patients as well, given the IV cyclophosphamide. However, with various mechanisms that are there, where you get ovarian preservation and use of gonadotropin releasing analogs, this risk is being reduced in our current setting. However, with the disease, when the disease is active, we usually don't encourage the patients to fall pregnant, and we want them to be on adequate comprehensive contraceptives. Because of the disease inherently, patients with, for example, secondary antiphospholipid syndrome, they may suffer from recurrent miscarriages and may have higher risk of poor maternal and fetal outcomes, where they have a higher risk of intrauterine growth restriction, premature deliveries, intrauterine death. They also get with a risk of neonatal lupus developing in these patients, as well as congenital heart block. So you find that because of the disease and because it affects mainly females of childbearing age, their maternal history becomes compromised. And also the toxicity of the drugs. When we speak to lupus patients, once we start them on treatment, most of the drugs are teratogenic, and you don't encourage the patients to fall pregnant while they are on the treatment, such as your mycophenolate mofetil, as well as methotrexate that we commonly use. So pregnancies have to be planned ahead of time. There can be pregnancy losses because of unforeseen pregnancies occurring without adequate planning. So you find that there's a lot of complexities, especially with dealing with pregnancy and maternity and maternal outcomes in these patients. Another thing we worry about also is the high cardiovascular risk in these patients. So besides the traditional risk factors which need to be managed aggressively, like hypertension and dyslipidemia, you find that lupus patients, because of the chronic inflammation, they get accelerated atherosclerosis. So these patients present at a younger ages with strokes, myocardial infarctions as a result of the disease itself, and this can be very debilitating to the patients. Infections we mentioned previously, and other comorbidities such as osteoporosis need to be managed in these patients. They're at higher risk, though we worry mostly about postmenopausal osteoporosis in most women. When it comes to lupus patients, though they are young, because of various factors, for example, we usually want them to have sun protective mechanisms, so they use a lot of sunscreen, they cover up, so they don't have enough exposure to the sun, and vitamin D is not activated, so they get vitamin D deficiency, resulting in osteoporosis. They also are at risk of osteoporosis due to chronic glucocorticoid use, which is needed to control their disease, and at times cannot be put off the glucocorticoids themselves. Another thing that we worry about is premature menopause that can result in these patients as a result of cyclophosphamide. So all these are secondary causes of osteoporosis which can happen to these patients. So how can we as healthcare providers help these patients? So I think importantly, we need to have mechanisms of early diagnosis and early referral of lupus patients. So once a patient is diagnosed with lupus, they need to be urgently referred to a center or a place where rheumatologists can manage these patients, give them adequate and early education to avoid all these complexities and complications that result from the disease, and try and establish a state of low disease activity, lupus low disease activity, or if possible, by the Doris definition of remission in these patients. A multidisciplinary team approach is required. So as treating patients with lupus, as doctors, we cannot do it in isolation. We need the help of other team members, other specialists, non-medical teams. They need to be on board. We also need to be able to identify and treat comorbidities associated with lupus, do things like lifestyle changes, smoking cessation, healthy lifestyles, which we shall talk about later on, and try to use the therapies that will then put your patients off glucocorticoids. So try and use glucocorticoid sparing therapies early in the disease so that patients don't succumb to the complications of glucocorticoids, and have a holistic approach to your patients. Identify things like non-adherence early in your patients, which can then affect disease activity and outcomes. Counseling, identify depression and anxiety in your patients, and also involve family in care. And importantly, every patient should be on antimalarials unless contraindicated. There's a lot of evidence showing the benefit of hydroxychloroquine or chloroquine in patients with lupus, and this should be part and parcel of management of lupus patients.
Now let's delve into the different types of lupus and the variations in their symptoms. Now, how do these differences impact the strategies for managing each type of lupus?
So that's true. So lupus is a broad term, and most of the time as rheumatologists, when we speak about lupus, we are speaking about the systemic lupus erythematosus. However, there are various other types of lupus that can present in patients and can be managed also by rheumatologists or dermatologists depending on severity. So the other type of lupus that is there is what's called discoid lupus erythematosus, or DLE for short. So this is a condition where you have only skin involvement in your patient. So these are lesions that usually affect the skin and the skin of the face and the head, causing permanent scarring lesions that are disc-shaped and can be quite deforming. Unlike lupus, there's no systemic involvement. So other systems like the kidneys, your cardiac involvement, your joints are not involved in this patient. So they have predominantly skin involvement. But however, histologically, the DLE lesions of DLE, as well as those skin lesions of DLE found in lupus patients, are similar. And you find that up to 1 to 5% of these patients can go on to develop systemic lupus. So they need to be followed up, especially if they have ANA positivity. So in terms of treatment of these patients, you want to do what are called photoprotection, where you tell the patients to avoid the sun because these are usually photosensitive rashes. You want them to cover themselves up and to wear wide brimmed hats as well as sunglasses, and to also use sun protective as SPF, at least SPF 50 sunscreen when they go out. So this reduces the risk of flaring up of the skin lesions. In terms of other medications we use typically for the DLE, hydroxychloroquine and other antimalarials have a good, shown good response in these patients. And when needed, you may need a topical as well as intralesional glucocorticoids. And then the use of other immunosuppressants such as your methotrexate, your mycophenolate, your retinoids also falls into place with these patients. So this is DLE, where you've got skin involvement, these scarring lesions that are permanent, that can cause a lot of disfigurement, but no features of systemic lupus. The other form of lupus we have is also a skin manifestation. This is called subacute cutaneous lupus erythematosus. So these are also very soft photosensitive rashes that can develop in patients, but usually these are elderly and it's more common in Caucasian patients compared to DRE, which is more common in your African and African population and Black. So subcutaneous lupus erythematosus usually affects the upper arms, the extremities, the trunk, and the back, so your photosensitive areas. However, the good thing about it is that it's non-scarring, but it can heal with hyperpigmentation, which can be permanent. It's usually associated with an autoantibody, anti-SSA or anti-RAW, which can be positive in patients with lupus or with other diseases, such as your primary Sjogren's and other connective tissue diseases. And it also typically can present as a clinical presentation in patients with drug-induced lupus, which we shall go into detail with. So treatment for the subacute cutaneous lupus is basically the same principles for that of DLE: photoprotection, sunscreen, use of topical glucocorticoids, and if severe, you may need to use other immunosuppressants such as your methotrexate, MMF, azathioprine, as well as your retinoids can be used, as well as Dapsone. So that's in your subacute cutaneous lupus. The third type of lupus we have is what's called drug-induced lupus. So this is an autoimmune phenomenon where patients present with symptoms similar to lupus. However, this only happens with exposure to certain drugs. They now start presenting with symptoms similar to systemic lupus. However, with drug-induced lupus, typically they are less severe. So you don't get major organ involvement, typically like your CNS or your lupus or your kidney involvement, but you can get cutaneous manifestations. So they present with rashes, more commonly the subacute rashes. They can present with arthralgias and arthritis. They can present with fevers, hepatosplenomegaly. And the good thing about this drug-induced lupus is that once you stop the offending drug, with time the symptoms also regress. And you actually get disappearance of these autoantibodies because these patients are typically ANA positive as well. However, they also have an autoantibody called anti-Heption antibody that's typically positive in these patients. In terms of timing of when the disease, how difficult it is because it's idiosyncratic. So it can happen within weeks of starting the offending drug to up to 2 years of starting the offending drug, and up to 100 drugs have been implicated. The first one was hydralazine, which was found to cause the disease, and this was identified in 1954. But now the list has gone up to 100 drugs that are used. And interestingly, now with the use of biologics, especially your TNF inhibitors for treatment of other autoimmune diseases, these can also predispose the patient to developing drug-induced lupus. So one has to be aware, especially when treating other autoimmune diseases with these agents, when they start developing other symptoms that are not typical of the disease you're treating, to be aware that this could be a drug-induced lupus, and the only way to stop the symptoms is to stop the offending drug. Treatment, if the stopping the offending drug will usually stop the disease. However, in severe cases, you may need to use low-dose glucocorticoids, such as in arthritis, when it develops. And rarely do you need to use other immunosuppressants in these patients, as they tend to get better with stopping the drug. So it's very important to be aware of this as clinicians managing patients when they present with features of lupus. Another way to differentiate SLE from drug-induced lupus is in terms of demographics. It's more common in the Caucasian and usually in the 5th to 6th decade, so 50 to 60 years, and the male to female ratio is 1:1. So this is typically very different from how lupus patients present, where it's mainly females, childbearing age, and African patients present more typically compared to your Caucasian patients. So these are some of the things you can use to differentiate between the two, because sometimes it can become very difficult to differentiate. The last type of lupus that can present is what's called neonatal lupus. So neonatal lupus is when a child is born with features of lupus as a result of autoantibodies being transferred from the mother across the placenta. So this is usually associated with lupus patients. As we know, they tend to get anti-SSA or SSP, which is your anti-RAW and LA positivity. but it can also occur in 50% of the cases in patients or mothers who are not symptomatic of any connective tissue disease. So they don't have features suggestive of lupus, they don't have features suggestive of Sjogren's disease where anti-SSA and FSB is common. However, they now have babies presenting with the disease, and it's only backwards that you now diagnose the antibodies in the mothers. So these antibodies then cause clinical presentations in the babies, and these babies are typically born with cutaneous manifestations, with rashes that are typical of or resemble your subacute cutaneous lesions. However, they have other system involvements where you can have hepatobiliary involvement, so they can present with transaminitis, with jaundice. They can have CNS involvement where they present with hydrocephalus, with or without macrocephaly. They can also present with cardiac involvement, which is something we worry about, where these patients can present with congenital heart block, as well as heart failure, and can cause morbidity and mortality in these patients. So this results in need for early screening of any patients with lupus who have anti-Rho or La positivity, or a history of a child born with congenital heart block. Treatment in these children is similar to that how you treat your adults. So use of glucocorticoids, topical or systemic, as well as other immunosuppressive depending on severity. But the good thing is usually this clears when the antibodies stop circulating in the body. So within 2 to 6 months, the babies can actually, it is self-limiting in the babies, except when there's major involvement or damage. So for example, a child born with congenital heart block may need a pacemaker to prevent mortality or heart failure, and others may later on go to develop complications as a result of this. So neonatal lupus is very important to identify and diagnose. Another strategy would be screening of the patients, where if a mother is pregnant and is found to have the antibodies anti-Rho or La positive, they start screening for cardiac monitoring of the fetuses from 16 to 34 weeks. And if they identify any heart block, there is a role of use of glucocorticoids, your fluorinated glucocorticoids that can cross the placenta, like dexamethasone. So this reduces the risk of the development of the heart block. However, once it's third-degree heart block or complete heart block, there isn't a role for the use of these glucocorticoids. And this, when the baby is born, there may be need for use of pacemakers. So all in all, lupus is a broad term. It's important to know whether we are discussing systemic lupus versus all these other types of lupuses that are there and can present in patients.
Thank you so much, Dr. Rutendo, for breaking down the types of lupus and explaining the variations in their symptoms. Now, shifting our focus, are there any recent advancements or promising developments in lupus research and also in terms of lupus treatment that patients and caregivers should be aware of?
So the field of lupus is quite exciting, and some highlights of the recently completed American College of Rheumatology annual meeting show that there is advancement in terms of therapy for lupus patients. So for many years, there were no FDA approved drugs specific for lupus. I think we only had chloroquine as an FDA approved drug, and not much in terms of, so most of the therapy that we use for lupus is actually taken from other conditions. So whether it's rheumatoid arthritis, whether it's other diseases where therapies are used, and these drugs were not really FDA approved for lupus per se. So exciting is that in the last few years, there have been great leaps in the advancement of care of lupus patients, especially with lupus nephritis. So in 2021-2022, we had 2 new drugs that were approved for lupus. Firstly, we've got a drug called anifrolumab, which is a biologic agent that was approved for the treatment of adults with lupus, which is moderate to severe lupus, and it was found to be very effective in terms of treating skin and joints. However, there's actually been now trials to try and see whether it can also be used in treatment of lupus nephritis, so that's an exciting area as well. However, it is not yet approved for treatment of lupus nephritis or as well as CNS lupus. Another drug that was approved recently is voclosporin, which is a CNI calcium urine inhibitor that was FDA approved specifically for the treatment of lupus nephritis. And this is exciting because there's been now the move towards multi-targeted therapy, where you use two agents initially in the induction phase of treatment of lupus nephritis, and is showing better response and better outcomes in these patients. So voclosporin is a CNI inhibitor that is now approved in 2021 for the treatment of lupus nephritis, and exciting in the research that there's been good tolerability and good outcomes in these patients. Another biologic that was approved in 2021 was the Rheumamed, which is an antibody, which is also a biologic against B-cell activation factors. And this, though, was approved in 2021 after decades of not having any FDA-approved drug specifically for lupus. So this was very exciting. And it was also approved for the treatment of adults with severe and moderate lupus, especially skin and joints. However, now in 2020, December, it has been approved also for the treatment of lupus nephritis in combination with other agents. So you don't use it as monotherapy, but you use it with other agents such as cyclophosphamide and MMF, and it's also showing good and promising results in that area. Also coming up from the recent ACR conference was that azathioprine has been shown to, over time, to improve cognition. Remember we said most of the patients with lupus have a lot of neuropsychiatric involvement where you can get cognitive dysfunction. So it was found that using azathioprine as a supplementary drug to even other immunosuppressants has been shown to improve over time cognition of these patients. So this is something that we as doctors and rheumatologists need to be aware of and consider adding to the care of our patients with lupus, especially those with severe neuropsychiatric and cognitive disabilities. Exciting also in the field of lupus is the CAR T-cell therapy. This is showing to show that this therapy is leading to the disappearance of autoantibodies. So hopefully leading to a point where we can provide a cure for lupus, which would be, very exciting in the field of lupus. So there's ongoing trials to this CAR T cell therapy and advances to say, can this be a treatment that can even bring cure to our patients with lupus? And there's also trials underway for the role of JAK inhibitors in treatment of lupus. Some are in phase 2, as well as other therapies that are with different mechanisms in the pathogenesis of lupus that are still undergoing trials. So there's a lot of research being undergone in the field of lupus with new therapies that are now available. They're not accessible and quite expensive, but with time, hopefully, they'll become the bread and butter in our treatment and management of patients. So very exciting times in the treatment and research regarding lupus treatment and therapy.
Now let's move on to our final question for the day. Emphasizing on the importance of multidisciplinary approach, could you please elaborate on how crucial it is in lupus management and what specific lifestyle changes can support the overall well-being for individuals with lupus?
So the need for a multidisciplinary team in management of lupus cannot be overemphasized because, like we know, the complexities and the degree of potential multi-organ manifestations in these patients makes it paramount that not one clinician or one rheumatologist should manage these patients. So the multidisciplinary team approach is paramount and necessary, and it can vary from patient to patient depending on what systems or the phenotype of the disease. So like I said, no two lupus patients are the same, where one can present with mild disease but others present with life-threatening multi-organ failure. So there's need for teams of specialists, medical specialists, as well as non-medical healthcare professionals to work together in the overall management of these patients. So these multidisciplinary teams can consist of other specialties such as the gynecologist, like we mentioned before, the planning of pregnancies, the higher morbidity and mortality and poor fetal and maternal outcomes associated with lupus. So you need to have discussions with the gynecologist when a lupus patient is planning to fall pregnant or is pregnant so that the outcomes are improved. We also work as rheumatologists, need to work closely with nephrologists especially when patients present with lupus nephritis and other renal manifestations of the disease, to prevent damage and end-stage renal failure needing transplant and renal replacement therapy. Ophthalmologists are also part of the team where we do screening for patients, as well as other ocular manifestations of lupus that can present, such as your retinitis that can be diagnosed by other specialties and managed accordingly. We also require pulmonologists for any pulmonary involvement which can be life-threatening, such as your diffuse alveolar hemorrhage and interstitial pneumonitis in this patient. Neurologists are key because of the neurological involvement, whether it's muscle, central, peripheral nervous system. We need a team with neurologists to manage these patients, cardiologists with the cardiac manifestations, myositis, pleural pericardial effusions that may need to be managed with cardiologists. Dermatologists, like we said, skin is a common manifestation in these patients. At times we need the help and the assistance of dermatologists for biopsies to confirm diagnosis, as well as to just manage the difficult skin and cutaneous manifestations. Other specialists that need to be on board include your hematologist, because of a lot of hematological manifestations. When a patient presents, for example, with TTP, you need to have a co-management with a hematologist on board, as well as infectious disease specialists. Like we said, infections are a leading cause of admission, mortality, and morbidity in these patients. So when they're admitted and they're growing all sorts of bugs, there's a lot of fungal infections, there's complicated bacterial infections. Infectious disease teams need to be on board to help manage these patients. And not forgetting our rheumatology nurses that are specifically trained to help and manage and counsel these patients. You need psychologists, occupational therapists, physiotherapists. So it's a broad, like I said, it's a broad team that needs to be in place, and resources allowing this allows for the best outcomes for the lupus patients. So multidisciplinary team cannot be overemphasized. Where possible, rheumatologists alone cannot manage lupus patients. Then in terms of lifestyle and life changes in the patients with lupus, like any chronic inflammatory disease, lifestyle plays a pivotal role in managing the disease, not only to reduce the flares, but also to manage in terms of the overall well-being of the patient. So a healthy lifestyle includes diet and exercise. So diet, we want the patients to be on anti-inflammatory diet. There isn't any research to say to show which diet trumps which one. However, there is recommendations for patients to adopt either a Mediterranean or a DASH diet, and anything that's going to allow the patients to maintain a healthy BMI, to reduce inflammatory foods, processed foods, in terms of high fat, high salt diets should be avoided. More plant-based, high fiber, nutritious diets are recommended in this patient. Exercise is important. Patients need to keep moving. Low intensity exercises or exercises based on the patient's ability is very important. Another thing in terms of lifestyle we want these patients to have is a good sleep cycle. So sleep is important in these patients. They need to rest well to manage their fatigue. That's also always associated with the disease, as well as mental well-being. Good mental well-being is important. There's a lot of mood associated with lupus, not only as a form of the neuropsychiatric manifestations of the disease, but also because of the chronicity of the disease and the complexities surrounding this chronic illness. There's a lot of mood, mental health is an issue for most patients, so they need to be aware of this and manage their mental health, whether it's stress relieving activities, as well as having psychologists and psychiatrists on board to help them to cope better. Other important things is smoking cessation. So patients with lupus who are smokers need to be counseled at every point and every time for the importance of stopping to smoke. Not only is it a risk factor for accelerated atherosclerosis in this patient, as well as the risk of reducing the efficacy of drugs such as your hydroxychloroquine when they smoke. Smoking is also known as one of the triggers that can trigger autoimmune diseases. So you really want to highlight the importance of smoking cessation in our patients. And importantly, sun protective measures, we mentioned them because one of the environmental triggers for patients with lupus is UV light. So ultraviolet A and B exposure can be detrimental. So you want to counsel your patients to know to avoid sunlight, However, bearing in mind that you now need to make sure you replace their vitamin D so that they're not vitamin D deficient if required. So sunscreen, cover up in the sun, broad hats, using sunglasses, very important in these patients. Even the sun can also trigger flares such as your skin, your acute as well as your subacute and chronic skin lesions can be sun photosensitive. And lastly, you want your patients to take an active role in their care. So lupus patients shouldn't be just passive. They need to take an active role in their management, work together with their doctors, work together with the supporting team, so that once they are on board, well educated, informed, empowered about their disease, it makes their management much better. They're able to pick up when they need to see the doctor early. They're able to pick up side effects and complications. Adherence and non-adherence issues are dealt with together with the doctor, because sometimes patients feel afraid to tell the doctor they're not taking treatment because of side effects. So these are some of the things that need to be dealt with on a day-to-day basis with the patients with lupus, and hopefully we improve their care, quality of life, and overall well-being.
Dr. Rutendo, we sincerely thank you so much for sharing your expertise and valuable insights on lupus management with us today. Your contribution is indeed invaluable to our listeners and also to our MedSynapse community. We're very grateful for the impact your knowledge will have to those affected by lupus. Thank you so much.
Thank you so much for having me, and it's been a pleasure. Thank you so much.
Thank you so much once again, and looking forward to many more podcasts together on our MedSynapse platform. And to our audience, thank you for joining us today. We appreciate your time and your curiosity. If you find this discussion to be informative, don't forget to subscribe to MedSynapse for more such enlightening videos. Stay tuned for our upcoming episodes where we continue to explore diverse medical topics with leading experts. Until next time, goodbye.